Well, we'll go on to the next speaker now. And speaking of excellence within the NHS, our next speaker is Dr. Fleur van Dijk, who came to us from Holland. She is an expert on connective tissue disorders, and she combines patient care and research in her profession as consultant clinical geneticist. She studies the clinical and genetic aspects of hereditary connective tissue disorders and leads the highly specialized Ehlers-Danios syndrome service in London, aimed at individuals with rare Ehlers-Danios types. She sees, together with her colleague, Dr. Niti Gali, individuals with suspicion of Marfan syndrome and related conditions in the Aortopathy service at the Royal Brompton and Harefield hospitals and in the Inherited Connective Tissue Clinic of the Northwest Thames Regional Genetics Service. We've invited her to speak because many of our helpline inquiries revolve around: how do I obtain a diagnosis of Marfan syndrome? I'm pretty sure I have it. Where do I go? And so Fleur is going to give us an up-to-date approach on diagnosis of Marfan syndrome. Fleur, welcome.
Great, thank you for the kind introduction, and that's really appreciated. I will just share my screen because that is quite important to do. Let me just get in full screen mode. All right, we're back. So I can imagine that you can all see it. And of course, the talk of my presentation today is genetic testing for Marfan syndrome: when, why, and the most important question, how. So I'll just move on to the next slide, which will be hopefully moving. Let me just say, yeah. So of course, we all know that Marfan syndrome is a rare condition, but it's actually one of the more common rare conditions with a prevalence of 1 out of 5,000. And I chose this picture, and you would say, well, wait a minute, no one of us looks like that. Because what I thought was really good is that this is actually a picture trying to capture most complications that you can encounter if you have Marfan syndrome, although of course you do not need to encounter them. And it's actually for medical students so that they are aware what this condition is. And considering the prevalence, it's just really important that medical healthcare professionals know what condition entails and are looking out for it. If we go to the next slide, I think it's important to go back to the basics when we're talking about genetics. And of course, I always mention that we all sort of build up of lots of cells, and these cells, they contain like a nucleus. In the nucleus is the rDNA, and it's packed in chromosomes, as you can see. And then, of course, little parts of DNA are called genes, and these genes, they make proteins, and the proteins often have an important role in our body. So in the 90s, the fibrillin-1 gene was identified to cause Marfan syndrome, and in particular, dominant disease-causing alterations in this gene were responsible for Marfan syndrome. And here I just pasted a family tree where you can clearly see autosomal dominant inheritance with just going from generation to generation. And what we know that if someone is affected with Marfan syndrome, there's a 50% chance in every pregnancy that the child is affected. And if someone is not affected, they cannot pass it on. So that's autosomal dominant inheritance in a nutshell. So if we're going to talk about when are we going to do genetic testing in Marfan syndrome, I think we need to go back to the Ghent criteria. And actually, I went back to 2010 when there were revised Ghent criteria, and they were used for diagnosing and making a diagnosis of Marfan syndrome. And we'll know these Ghent criteria very well because she was very strongly and heavily involved in this paper. So the criteria were the following: if there was no family history of Marfan syndrome, to be able to have a clinical diagnosis of Marfan syndrome, people would have an aortic root dilatation, so an aortic root widening with a Z score of 2 and above, and ectopia lentis, so that would be lens subluxation or dislocation. They could also be classified as having Marfan syndrome, again with the aortic root dilatation and a disease-causing change in the fibrillin-1 gene. Next possibility, again, the aortic root dilatation, which is quite crucial, and a systemic score, which I will explain later, of 7 or more to get a clinical diagnosis of Marfan syndrome. And then again, the last one, in the absence of family history, if you had lens dislocation and a fibrillin-1 disease-causing variant associated with aortopathy. If we go to the possibility where there is a positive family history, again, the aortic root dilatation and the lens dislocation would be enough to have a diagnosis clinically of Marfan syndrome. Aortic root dilatation and a systemic score of 7 or more, and also possibility of having an aortic root dilatation, the Z score 2 or above the age of 20 years old, 3 or above below the 20 years of age. And of course, family history of Marfan syndrome would mean a first-degree relative with Marfan syndrome. So there are all these criteria on which you could make a clinical diagnosis of Marfan syndrome, which is still helpful. Talking about the systemic score, because you heard it mentioned, to be able to obtain a clinical diagnosis of Marfan syndrome, both sort of with and without a family history. You can see the systemic score here, and what that really tried to capture here in this table is features that you can encounter in people with Marfan syndrome that are quite specific. So, for example, when we talk about the wrist and the thumb sign, and I depicted those signs here on the slide as well, they are a measure of how long your fingers really are, a measure of arachnodactyly. And it's something that you can test, and actually not many people will have a positive wrist and a positive thumb sign. Of course, also pectus carinatum deformities or pigeon chest, spontaneous pneumothorax. And there are a few in this systemic score as well, which are a bit more common. For example, stretch marks. There are lots of people, of course, having stretch marks. So that's a less specific criterion, but what in our experience you can potentially see is that the stretch marks can also be at unusual places, for example, on shoulders and on knees, where you would often not encounter them. And so the list goes on, and there are points awarded to every feature. And in the score of more than 7 is considered positive with a strong suspicion on Marfan syndrome. Moving on to the next slide. So talking about a clinical suspicion of Marfan syndrome based on a systemic score, this often concerns people under the age of 18 years. So often it's the GPs and the pediatricians that are often the first port of call, because, for example, parents of a child will come and say, well, my child is quite tall and he's got long fingers. We've heard about Marfan syndrome, we did Googling, and potentially could this be the case? And the pediatricians sometimes, when they of course see actually children for other reasons, note that they're very tall and they have very long arms and legs, and then wonder about the possibility of Marfan syndrome. And what if that's the case and they do an examination themselves and they think, oh, wait a minute, this could be Marfan syndrome. What often happens is that they refer on to the local genetic service for assessment for Marfan syndrome. Well, and then of course it's important what's actually going to happen and what happens at the local genetic service. So just a quick overview with regard to the UK. So just the red dots are the genetic services in the UK where patients are being seen in which there is a suspicion on a genetic condition. And it's important to know what's happening during an appointment. For if there is a suspicion of Marfan syndrome, what you can expect is that the geneticist, the clinical geneticist, will ask you, of course, about the medical history, and also then continue with the family history, which is of course quite important. And we'll ask about heights of family members, cardiovascular complications, collapsed lung, all these things will be inquired about. And then a physical examination will be done with specific attention for the systemic score that we just discussed, looking at what clinical features does this patient have when we do a physical examination. And then, as also mentioned before, if there is a strong suspicion, for example, because the systemic score is quite high, we do proceed with genetic testing. And that's of course, I will explain more about this as well. So another scenario when people sort of can be referred is because there is a clinical suspicion of Marfan syndrome, because there's an aortic root dilatation with or without a lens dislocation. And then it's often the consultant cardiologist, or if there is a lens dislocation, the ophthalmologist, who refers to the local genetic service. And also nowadays, the consultant cardiologist can also refer directly themselves for genetic testing. So patients are not always seen in the local genetic service anymore. The cardiologists can refer directly themselves as well. I think an important feature to discuss is, of course, also thoracic aortic dissection, which is importantly not specific for Marfan syndrome. It can also occur if it's not a monogenic condition, and it can also occur because of other genetic conditions. So when are you going to think about a potential underlying genetic cause? There are a few criteria that I've pasted there. So when there is a thoracic aortic aneurysm or dissection with onset before the age of 50, that's enough to think about a monogenic condition and arrange genetic testing. The same as when it occurs before the age of 60 with a first degree relative with a thoracic aortic aneurysm or dissection. Also, if it's before the age of 60 with no classical cardiovascular risk factors, so no sort of very high blood pressure, for example. And the last one, before the age of 60, with features suggestive of aortopathy. And I just pasted a picture of arterial tortuosity, which can be a sign of monogenic conditions that also can lead to thoracic aortic dissection. And you can see that the not yellow arrow is, you can see that the vessel is quite tortuous. So important to note here as well that the consultant cardiologist or the consultant geneticist can refer for genetic testing, so they can initiate genetic testing. But any medical professional can store DNA in the local genomic laboratory hub. And that becomes important for something that unfortunately happens as well, is when someone passes away because of a sudden death due to a thoracic aortic dissection. And what we're really trying to do is raise awareness that it's important, definitely, if we keep in mind the criteria that we just discussed, when do we think about a genetic cause, it's really important to store the DNA, to not only sort of mention actually the death has been caused by a thoracic aortic dissection, but to look deeper and further and think, wait a minute, why did this person had the dissection at such a young age? And then think to store DNA, which can simply be done by taking a blood sample and sending it to the local genomic hub from the deceased. And this is, as I also mentioned in the title, very important for family members, because there might be children, first degree relatives, who are wondering whether they might sort of have a similar risk of a thoracic aortic dissection. And then if you can do genetic testing eventually on the stored DNA sample from the person who is deceased, there can be more clarity if there's a genetic change identified that causes it, and family members can be tested for it. And unfortunately, in our experience, it does often not happen. So often there's no tissue or no blood sample available to test, which makes things quite difficult. So moving on to the next slide. One again, of course, when there's a suspicion of Marfan syndrome is when there's a family history of Marfan syndrome, and often when there's a first degree, the suspicion is highest because then there's a risk of 50% to have inherited the disease-causing change. And then people are often referred to the local genetic service again for predictive testing to find out whether they have Marfan syndrome, certainly predictive testing if there is a genetic cause already known in the first degree relative. So we're talking about when people are referred for genetic testing, but why actually would you need it? Well, we already heard a bit about it with regard to the family, but there are other advantages of genetic testing. It's often helpful to determine whether cardiovascular surveillance is needed, you know you're affected, and what this surveillance would entail, because sometimes it's really important to know what the exact genetic cause is. For example, the criteria for aortic surgery differ for Marfan syndrome versus, for example, Loeys-Dietz syndrome. And also, it's important to decide on management during pregnancy and delivery. It can be important with regard to decision making around family planning, as I already mentioned, to enable screening of family members. And also, and of course, that's very, very important, development of new specific therapies, personalized, and thinking also about personalized medicine. So these are the advantages of genetic testing in a nutshell. So then I think the most important question, and the reason why Anne actually asked me to give a presentation, is how are we going to arrange genetic testing then, and what exactly is it? So I just always like the picture on the left side, DNA analysis, where you see our DNA on the couch being analyzed. And actually, of course, when we do genetic testing, we basically look at the genetic code. And the genetic code consists of letters. And if you look, this is actually an exon in the fibrillin-1 gene, and the nucleotides are always read in triplets. So ATG makes an amino acid, and TTC makes an amino acid, and all these amino acids together, they form a protein. And you can imagine when you see all these letters that if something goes wrong, and for example, if you look at this picture, if something goes wrong, and here there's an insertion suddenly an extra T and an extra G are inserted, then complications arise. And you can immediately see that here, the code, you can see there's a nice A, there is a G, there is a T. And here you can see, wait a minute, after addition of these two nucleotides, this code gets messed up. It's not clearly readable anymore. And that, in fact, is a mutation that has been reported in the fibrillin-1 gene and causes Marfan syndrome. But this is just an example. And this type of problems can happen in genes also, of course, for different conditions. So what we're doing when we're doing genetic testing, we're looking at the code, we're looking at all these letters and see whether there are any mistakes. Are there in the insertions? Are there letters added? Are there letters swapped? Are there letters missing? So there's a lot of things you can discover when you look at the genetic code, and it's the genomic laboratories who do this type of testing, who perform the actual testing. On to the next slide. So, okay, so we know a bit more about what happens, but what do we need for genetic testing? And actually, we don't need much. You heard me already saying that a blood sample would be enough to store in case that someone passed away. And here's actually what we would need. We would need preferably 2 tubes, specifically EDTA tubes. That would be helpful because the DNA is better preserved in those type of tubes. And that's where we can generate lots of DNA from. And so this is what we prefer. We can also extract DNA from tissue. We can extract it from saliva, but from blood, it's still most helpful, most pragmatic. So let's say we have a strong clinical suspicion of Marfan syndrome in someone. We have taken a blood sample. What needs to go with the blood sample? And of course, that is a no-brainer. We need a form to go with the sample, with the details of the patients, and also the clinical details, so that the laboratory knows why actually we've sent this blood sample for analysis. That's quite important because they are going to look at, among others, the fibrillin-1 gene and are going to see whether there are any abnormalities and can relate that back to the clinical information. So we have a strong connection usually with the laboratories, and we often share cases between us. So I've been talking about the fibrillin-1 gene because that's the gene in which disease-causing changes cause Marfan syndrome. And for some of you who might have been tested quite years and years ago, they might remember that they had a single gene test. So only the fibrillin-1 gene was assessed and no other genes. But since approximately 2009, 2010, there are new techniques where you can test actually multiple genes in one go. And that's why at the moment there is an aortopathy gene panel. And this is what I've depicted in this slide. You can see that there are quite a lot of genes in here, including the fibrillin-1 gene. So in lots of people who have aortopathy, so they have problems with the aorta and potentially also other vessels, this panel is applied if there are certain specific criteria that they fulfill, which I come back to later. Then I also want to mention that genetic testing in the NHS is not fast. For most gene panel testing, it takes at least 4 months to have a result back. And if there's one specific mutation that needs to be analyzed, then the results come usually back much quicker, within 6 to 8 weeks. That's just for people to know, because often people are surprised that genetic testing takes such a long time, because in certain detective series, it's often when you talk about genetic testing and DNA, the results are back in a week or so, but that's not the case if you have to do a thorough analysis of multiple genes in this case. So I'm not going to go through this because this is a far too busy slide, but there are specific criteria when you send in to aortopathy, when you send in a sample for aortopathy testing. And you can already see that a few of the criteria that we discussed, for example, features of Marfan syndrome giving a systemic Ghent score of 7, is one of the criteria. So of course it's very good that we can assess for multiple genes in one go, but the more you assess for, the more you may find as well. And you sometimes find things that you were not really after, that you were not really looking for. So when you think about changes in the DNA, we just sort of looked at the code, we looked at the letters. We all have alterations in our genetic material, and you can classify these changes. And you have actually a classification in 5 types, going from disease-causing to likely disease-causing, to unknown significance, basically saying question mark, we're not sure, it could be disease causing, but then again, it could not be. And then going to likely benign, so likely not disease causing, and benign not disease causing. And in the past, well, and it actually before 2015, there was quite some discrepancy between how variants were classified. We've had issues where, for example, one lab said actually this change is likely benign, and the other lab said actually the change is likely pathogenic. And that was often quite difficult for both the clinician, the clinical geneticist, and of course also the patient. But since 2015, there's a new sort of variant classification, which is quite strict and really well defined. And all the genomic laboratories in the UK are using this specific classification so that there's consistency in how genetic changes are classified. going back to when we received the result, as for example, geneticists, we received the result of a genetic test, and we find that there is a variant of unknown significance reported. So usually the lab reports on the hot variants of unknown significance. So those are the ones that just don't have enough points to be considered likely pathogenic, but they are suspicious. So they do report them to us. And then there are a few things that we can do to try to sort them out. And of course, the first thing we always do is discuss this with the patient who we ask genetic testing for. And in fact, we often pre-discuss genetic testing with patients and explain to them that you can have the possibility that when we do genetic testing, we'll come up with genetic changes that we're not exactly sure of what it means, so that they are a bit pre-warned. So what can we do? We can do in segregation analysis, which is a fancy word looking whether other family members have the same clinical features and also have the variant of unknown significance. And if you have enough family members who have similar clinical features, for example, dilated aortic root, and they all have the VOS, that's quite, that gives you more evidence that it's likely the cause, this VOS. It can also, you also can look whether it's a spontaneous variant. So is it de novo, so not inherited from parents? That also gives extra weight and makes it more likely to be disease causing. Then there are functional studies that you can do. So sometimes you have to see what a change that is identified actually do. And there are tests that you can do for that. And sometimes that requires other tissue, for example, a skin biopsy or a new blood sample. And then if we sort of exhausted all possibilities, what we often say, well, let's revisit in a few years to see whether the VOS that has been identified has been reported by someone else in a patient with the same condition, because nowadays there are lots of databases, excellent databases, where variants that are being encountered in genes that are quite common are reported, but also disease-causing changes are reported, which is very crucial for many rare diseases. So these databases that are accessible internationally are very important. So this is the story in a nutshell. Thank you for your attention. And Niti, my colleague, will join me also for these questions, so yeah, thank you for your attention.
Thank you so much. I think you've answered questions from a lot of our patients. And as I say, if you listen to Victoria's talk later on, an analysis of the helpline requests, this is a very frequent one. People end up quite puzzled, or they say, you know I have Marfan syndrome, but they couldn't find a mutation. That's a very puzzling situation. Another patient rang in and said, I have Marfan syndrome, my mother has Marfan syndrome, but she has the mutation and I don't. So we do need to explain to the patients what these mutations mean, or else they walk away very unsatisfied and wondering the rest of their lives. Or, I think I have Marfan syndrome, but the doctor wouldn't do a blood test. And then, of course, the rest of their lives, they wonder if they really do have Marfan syndrome or not. So, and that's because I think of financial restrictions. But these are all cases. Can you offer any explanation to a patient who has a mother with Marfan with a mutation and the daughter does not have the mutation?
So I think, yes, I would say if there is a mutation identified in the mother that sort of causes Marfan syndrome, and the daughter has been tested for that specific mutation and does not have it, I would say that is very reassuring. The chance that there would be a different change in the Infornation 1 gene is so very small. And then, of course, I would say she probably has been seeing the testing has been requested potentially by a geneticist who, what I always do also in clinic, if people are coming also for because of a family history, I do assess them in clinic as well, just to see what kind of features on the outside do they have, do the systemic score, and then really try to explain what I think will be the outcome of the test, but of course then actually doing the test. And I think I would say if she doesn't have the genetic change that her mother causes Marfan syndrome in her mother, that's reassuring. I wouldn't be worried.
Good point. Good point. Because the chance of having two different mutations in the same family is so very small, isn't it?
It is very small. And then that's why I always like to do an assessment, even if the mutation is already known and someone is just coming for genetic testing for the mutation. It's important to just have a look and do an assessment for example, the systemic score to see how high this clinical suspicion is.
Another question we get is, I went to see the geneticist and they examined me and took a history and they said I didn't need a blood test. Now, these patients really want to be screened and told that they're negative. Can we refer them for private genetic screening for the Marfan gene?
I think that private is always an option that people have, of course. I think that is an option, and some people do take that option. I think within the NHS, as you say, there are criteria for testing, and I must say, if you don't meet the criteria, then the genetic testing can't be done. But that's of course different with in the private sector. That's a different story because you basically pay yourself for the testing. So yes,
I think psychologically it can be very important to have that question mark removed. Thank you very much.
Yeah, understand.
Over to Victoria. Any questions from the audience?
I have a question actually. A patient approached our helpline. She's always considered herself as a de novo mutation in her family, but her father has subsequently been diagnosed with mosaic Marfan, which I hadn't heard of. And I forgot to ask you about it, Anne, actually, because it's only just recently happened.
Yes, so this is a good question, and it's always a difficult one to explain. But if you think, let me explain it like this. So people with Marfan syndrome, as we know, often have the genetic change in the fibrillin 1 gene in all their cells. So if you look at any cell in the body, this genetic change that causes Marfan syndrome will be there. But what happens in people who are mosaic, it means that they do not have the genetic change in all of their cells, but in a portion of cells. That's why they're called mosaic. They're actually a mosaic of cells who do not have the mutations and cells that do have the mutation. And often, but not always, because of that, the clinical features are less clear or milder. So it's a difficult one, but mosaic basically means that her father doesn't have the mutation in all of his cells, but in portions of his cells. And it's difficult to determine what percentage. That's because potentially only have looked in cells coming from the blood. You don't know how it would be in skin cells. You don't know how it would be in cells in other parts of the body. So it's a difficult one, I should say.
But he would presumably have passed on. I mean, she would have inherited.
Yeah, that you can see, that you can be certain of, because she has inherited it. So he must have had in his a part of his sperm cells. He must have had the mutation.
And it's manifested itself more severely or more obviously in his daughter. Exactly,
because she has then the mutation in all of her cells. So when the sperm cell and the egg cell come together, and the sperm cell carries the mutation, from there off, of course, you have the embryo that sort of develops further. The mutation is in every cell. So that's, for her, it's different than it is for her father.
And in the context of de novo mutations, when does the mutation evolve? Does it evolve during pregnancy or before?
So it's before. definitely. But we don't know exactly what causes it. So this is often so, and so often people ask this. So why do I have this genetic change? And then I mentioned we all have genetic changes in our DNA. We all have changes, and some of them, of course, occur at positions and or type of changes that are causing a problem. And some of them are very innocent, but we don't know exactly how that sort of exactly works. So it's the de novo mutations. It's just a given. It's something that happens.
And I think Sarah has her hand raised.
Hi, yeah, thank you. Hi, Fleur. Thank you for the talk. That's really interesting.
Thank you.
I'm just wondering on that point about the mosaic, Marfan. Is that potentially why, as Victoria mentioned, some things are so varying in families? Like in my case, I haven't got the kind of outer aesthetic symptoms, but I've had horrific problems with my aorta. I've had surgery very young, dissected, and whereas my father didn't, he kind of, he's 70 now, and he's sort of skated by with far less problem with his aorta, but more of the clinical, the like aesthetic symptoms, as I say. Is that down to that kind of mosaic effect?
It could be possibility. I don't know how much that has been investigated in your father, but also the other possibility is that there is intrafamilial, as we call it, variability in Marfan syndrome, in the sense, and that you can see that there are differences in severity or differences in what symptoms people have in family members. And that's always, of course, a big question. How is that possible? And then what I usually mention is that, of course, we also have other genetic material. Not only this genetic change in the fibrillin 1 gene, you also have other genetic material that determines who you are, basically. And sometimes what we think is that there might be changes elsewhere, or potentially in the same gene, that can be either protective, that can just give you give you more protection, or can be actually less protective. And this all sounds a bit vague, but it's definitely, I know that there are already researchers out there, amongst one of them in Ghent, exploring this and trying to see, are there modifier genes, as we call them, are there modifiers in our genetic material that that modify how severe and what features exactly people have with Marfan syndrome. But we are not there yet. It's a really difficult one, and it's a good question. But yes, this is what I can say about it.
You've been magnificent. Thank you very, very much.
Do we have time for further? Sorry, just a couple of questions emerged on the chat feed.
Yes, well, excuse me, but we're going to have to move on.
Okay.
But can you keep those questions?
Yes.
And we'll answer them afterward. If I can't answer them, can we pass them on to you, Fleur?
Yes, of course. I'm always happy to do that. That's fine. No problem at all.
Thank you for coming. We've come a long way in genetics, but obviously we don't know everything yet.
No, there's more to discover, definitely.
That's right. Every question answered raises at least 20 more. But that's the fun, the excitement of research, really.
Yes.
So, thank you very much for your help. And we'll come back to you if we have anything we really don't understand. Thank you.
Thank you very much. Bye-bye.